colleague, Dr. Gohshhajra, who's here from Mass General. Dr. Gohshhajra is actually runs the cardiovascular imaging component of Department of Radiology at MGH, and he has really been instrumental in helping us sort of work with our SCAD population. In addition to, he's really a great member of our adult congenital team and has specialty in sort of cross-sectional imaging of arteries, the veins, the heart, et cetera, and really has published extensively in this area. So he's going to talk to us about utility of MR and CTA in diagnosing SCAD. Right?
Thank you, Dr. Wood, and thank you, Dr. Salah, for the introduction. My disclosure is nothing really too relevant. I was going to try to come up with like a hashtag and SCADvocate. I thought it'd be great. And then I Googled it after the plane landed, and it turns out that's the name of the newspaper in like South Carolina. So I guess I'm not that good. So I'm going to argue that CTA is often, but definitely not always, the best test for SCAD diagnosis. So there's three situations where I think it might be useful, and I'll talk about MR as well, but I'll keep it simple with CT for the most part. So initial evaluation, elective workup of a new diagnosis, and then clarifying a suspected diagnosis. I kind of want to take that last slide of Jacqueline's and just kind of repeat it, but control F it, put in CT, because you have to be careful in all these. But I'm going to take a page from you as well and do it quick. So let's look at these images. No, I'm not, I'm just a slow radiologist, so I can't do the city images so quickly. But I'm going to show you 6 cases here, and I want us to vote on who thinks which case is a SCAD. Who thinks case A? All right, so a couple votes. All right, that's mattering. How about case B? These are all different patients. All right, handful of B. How about C? All right, you gotta be careful interpretation. How about D? All right, remember type 3 SCAD can mimic CAD, so how about case E? All right, I'm not going to make you classify with the classification, because no better way to get into trouble than presenting someone else's classification system to themselves.
Afterward, are you going to tell us you're not a robot?
and case F. Okay. All right. So here are the answers. So I've circled all the SCADs. So A, B, C, and F are SCADs. I'm going to show you each one of these in the course of this talk. And I'm going to show you why the adjunctive information from additional imaging, which somebody really smart right in front of me just said can be helpful. Okay, so evidence for CT and SCAD is not very much. 50 cases in the literature. We have 0 RCT, or 50 citations, I should say, not even cases, but 50 citations, 0 RCTs. There's a Mayo virtual registry where they compared CT and cath, or that was a 14-patient study, at least the one that I called when I made the slide. We had a registry of 1,403 patients, 11 of which had perivascular staining, and only 2 of those had the actual SCAD. So a rare finding and even more rare diagnosis to validate that finding. That's one of the findings. And then a bunch of case reports, a small series. So we have to approach all this with a grain of salt. And we have a nice guideline statement for that. I'm going to pull just a handful of statements out of that really nice guideline, the leaders of which many are here, and we owe a lot of gratitude to. So I'm going to read the yellow part. So no dedicated study has addressed CCTA in the setting of acute SCAD. Definitely agree with that one. CTA is generally contraindicated in patients presenting with high-risk ACS. Yes, the CT suite is a terrible place to code. If you really need to deal with an acute patient, the cath lab is a much more safe environment. The more of a normal results on CTA do not exclude CAD. I think you can say the same thing about cath, but fair enough. And you have to interpret with great caution. And I hope you all know I interpret all CTAs with great caution, as you interpret all the CATs with great caution. SCAD appearance on CTA differs from that of typical atherosclerosis. Yes, that is the most important thing. Take one thing from this talk, just remember that. And these features are unique and they can be challenging to recognize and can be unidentifiable small vessels. Yes, that's very important. Similar problem in cath, but it's more important in CT. And then a study of 24 patients with SCAD with follow-up CCTA found it to be a valuable non-invasive study without complications and identified healing in most. And we're going to see a lot of that in this. In fact, we just did see a lot of that. So on the question of invasive angiography, care must be taken to ensure that SCAD is not misinterpreted. I can't say it any more than Dr. Salah just said. There's intrinsic risk. We'll touch on this. So there's a reported prevalence of complications 3.4% over a baseline of less than 0.2% for just diagnostic standard invasive angiography. So 17-fold increased risk for that trip to the cath lab. So we don't do it lightly. And you know, we know the fragility of the arteries is what leads to that potential complication. Here's the summary of the data. I'm not going to read it all for you, but the first two columns are all recent studies. They're all small numbers of actual SCADs, a big population stream through the hard work that Dr. Saw and others did. So just so you know, all of this is in a kind of a low incidence and low number of patients kind of situation. I'm not going to rehash too much on this, but we're looking for thrombus in a false lumen, and when we do that, we want to compare the advantages and disadvantages of CTA and invasive coronary angiography. So spatial resolution, the big winner is cath by several fold. The spatial resolution, the pixel represents smaller voxels, smaller amounts of your vessel in the cath lab. The temporal resolution is far superior by cath lab. It's just a flicking x-ray. It's much more complex than that, but it's a lot easier to reconstruct that image with a planar cath. The contrast type is intravenous with a CT, it's intra-arterial, intracoronary with a cath. The big advantage for CT, so I would say that's one advantage, but also a disadvantage. You can't save anybody if you're going to give a fossa IV. But you know, what you can do is see 10,000 densities on a CT scan. So you know, when you see in the CT report it says Hounsfield units, that's the inventor of CT. The CT can depict so many more densities that we can't see them all with our eyes. Your eyes can perceive about 64, 65 colors. When you're looking at something, that's why we have the window width and level. So we look at lung windows for lungs, we look at bone windows for bones, we look at myocardial windows for myocardium. So the CT contains a lot more information about a lot more stuff, and that includes the vessel wall. So we use this stenosis paradigm when we're looking for CTA reports, and this is CAD-RAD, so that's when you deal with atherosclerotic narrowings, but basically we don't try to call percentile stenosis. We're looking for none, a little bit, a little more. We don't worry until it's moderate stenosis, so about halfway, and then severe stenosis, and then of course occlusions. So really CT is high negative predictive value because we're very sensitive. We pick up that plaque. And so the sensitivity is very good for atherosclerotic narrowing. I'm going to argue that we were pretty good for the stenosis we don't need to worry about here. Okay, this is a real case. This is the first SCAD I ever saw, both on cath and on CT. So this is a 54-year-old woman. She was visiting her elderly mother in our hospital who had a stroke. So a stressful situation. She's a self-professed type A person. And you can stay overnight in our hospital in the beds and with your loved ones in the neuro ICU. And she rang for the call bell the next morning saying, I feel this tearing kind of blossoming feeling in my chest. And you know, when I saw the referral come through the CT, I said, I don't believe there's such a thing as spontaneous dissection. Then I saw this careful cath, and you can actually see staining of a false lumen, a little filling defect there, and you'll see how the vessel flares. Okay, I believe it's the real deal. I don't know if I'm going to be able to see that on a coronary CT though. So here's the matched view. So this is an inverted. The advantage is to match that cath view. What you see here is the same caliber change. This is a 3-month follow-up just to make sure you're doing fine. I just wanted to make sure you can get worse and new diseases. And of course, no atherosclerotic narrowing. Another ancillary benefit of the CT is that we can follow up the wall motion abnormality on this careful echo done at bedside the day of the acute SCAD. There was an apical wall motion abnormality. It's a little hard to see. I try to make my side black. It's a very elegant thing. Keep the room dark. But the CT here shows that it's in complete resolution of that wall motion abnormality. Doesn't cost much radiation to get the function these days. I won't talk too much about this, but we know there's a lot of risk factors that go along with patients that get SCAD, and so we should be thinking about that, especially if we have that history, and I'll talk more about that in a moment. But so I think what we're really talking about is how do we use CT. So there's 3 situations. Number 1 is initial evaluation. So let's see an initial evaluation case. So this is one of the cases I showed you as well. So this is a 20-year-old male. Atypical case is a man. He had pain after weightlifting yesterday. So he had, went to the outside hospital 10 hours after having pain after weightlifting. I lifted off the slide. He also smoked some pot and slept it off. Maybe not the best way to deal with your chest pain, but you can see. And then, a PE study was done because that's what outside hospitals do. And then they checked the troponin, and it came back through the roof. That's old school troponin. That bought him a helicopter ride and a cardiology consult, which led to a request for a CTA, thinking maybe he lifted weights and pinched off anomalous coronary. But on the first slide of this image right here, you can see no anomalous origin. But what you do see is something really fishy going on with the RCA. Let's reconstruct that. So let's lay this out. The center image is a curved planar reconstruction. I've outlined in blue the vessel walls, and then short axis reformats all along the corner here. You can see there's a percentric true lumen with an eccentric false lumen that completely occludes the distal. This is a spiral dissection here, occluding the RCA. You get the wall motion. Everyone knows the RCA supplies the inferior wall in most people, just like this guy. And you can see it's thin, it's hypokinetic, it's hypoenhancing, it's got a subendocardial perfusion defect. This is an acute or subacute now MI by CT. Overall, they preserve most of the ejection fraction, going down a little bit. Okay, so we did a cath because that's what we used to do back then, and that's what interventional cardiologists do. And so one day after the CT, we went and did a cath, and they saw this, and it appropriately stopped right there. 2 weeks later, I had some chest pain, but you can see just medical management. He looks a million times better. Even I can see that on the follow-up cath. So right kind of care was done, and so this is one of the first cases we saw in this acute setting. Came in through the ED. Here's another ED patient, initial diagnosis. 44-year-old woman with tearing chest pain after a text from her man. I want to know what that text said, so I can never write that thing. She got a calcium score of 0. There's all this medical Twitter is kind of useful, but it's also got a lot of sayings and stuff, and one of them is the power of 0. Calcium score of 0 is not at all reassuring if you're symptomatic. Calcium scoring is never for symptomatic patients. This patient would have been misled very strongly by a calcium score of 0, but you can see here, expansile vessel here with perivascular straining, one of those 2 patients that we saw, and then near severe stenosis upon near total occlusion of the LED. You can see the tubular narrowing in the cath lab that was done sometime the next day that followed. You can also see wall thinning and a kind of a hypoperfusion of the LED territory there. So I guess texting is texting works. Be kind on text, okay? All right. So if you look at coronary CTs done in our ED, there's about 1,000 patients. People that have a negative scan do really well. So we're using CT for the negative predictive value, and we're also using it to find atherosclerotic narrowing in most cases. But those people with calcium scores of 0, there's 0.5 to 5% of them are going to have occlusive disease, and SCADs are probably the large majority, in my opinion, of them. All they can just have lots of lipid-rich plaque. The other thing is you got to think broadly, right? You don't have a diagnosis yet, especially if you're in one of these low-risk, general low-risk CTs. So you're thinking about anomalous coronaries, embolism, hypertrophic cardiomyopathy. So cast a wide net, don't just hone in on that one diagnosis. Let's talk about elective workup of the new diagnosis. So here's a CTA done to follow up an outside diagnosis of MI. One of our, at the time, younger cardiologists referred this in, and she was shocked to see a report of normal coronaries, which the outside cath showed, but evidence of an apical MI. She said, I thought maybe it was just a misdiagnosis or some other kind of myocarditis masquerading as a STEMI. Well, so there's a thinning of the apex here. I think anyone in the room can see that. And I'll show you the normal coronaries, but with that kind of discordance, Dr. Watsky went and requested all the outside films and said, let's look at this for ourselves. So she found an echo that corroborated a large wall motion abnormality in the apex. She found a cardiac cath reported as normal, but you can see here on the invasive angiography, there's a vessel that's missing that's recanalized by the fall. I don't know how far after the CT was done. But I think maybe it's hard to see, and I think everyone implores you to be careful with these, and so that's a value. And this is not in the acute setting, but in a follow-up and to clarify diagnosis. And so maybe I'm going to throw some air quotes around that end. The negative or non-occlusive is a subjective thing. It's very distal. So it's hard to see distal vessels on any modality. It's also hard to see flush occlusion, so CT can be useful for that. And as you can see, CT was good for myocardium here. MRI is great for myocardium as well, and you can probably see abnormal link all through that apex. In fact, we can also do ancillary imaging. I will talk on this tomorrow, but I'll quote the master here and say there's concomitant FMD up to 50% of SCAD patients. In Dr. Wood's analysis of our registry, we found when we imaged all the vessel beds, nearly everybody had some kind of arterial fragility marker, like tortuosity or dissections or beating. So not always FMD, as you've already heard, but some kind of argument for arterial fragility. And this patient was pretty flagrant bilateral renal artery beating. So we can actually use our scanners these days in most hospitals to get a kind of general screening for most vessel beds. You can also do MRs for different, especially in the neurovascular circulature. But here's a patient with FMD and resolved coronary dissections. In fact, they didn't even carry a diagnosis, but you can pretty clearly see the anteroseptal apical wall has fixed spinning, and that's an old MI. So in spatial, pretty flagrant renal and iliac FMD. So you can combine all the vessel beds to increase your sensitivity and increase your diagnostic certainty. So here we are clarifying a suspected diagnosis. But the thing is, if you're not sure of the diagnosis of SCAD, don't just, it may be worth doing further. Here's a case where it became the diagnosis du jour recently, thanks to the work of those in the room. And so here we're presented with a 36-year-old woman after prolonged labor. We know pregnancy and PSCAD is a big one. New nausea, elevated troponin, that's the old school troponin. Clinical team was highly suspicious for SCAD, but the coronaries were normal. There's really nothing you can call, no CAD, but no narrowing. So are we missing the SCAD? Is this the case? We're saying be careful because we're not going to catch the severe, the subtle stenosis and the distal things. But remember, you can look at the myocardium. And so here's the anterior and the anterolateral wall, maybe some anterior septal wall thinning, hypoperfusion. This is a functional data set. It doesn't really need a lot of X radiation. We just happen to get it here. You can see that the anterior wall is hypokinetic, echo corroborated. But what do you do when you really want to be sure about myocardium? You do an MR. MR is super sensitive. It's 25-to-1 contrast to noise. So here's your MR. Minimal edema in that territory. No significant abnormal late limb cancer. That's where you go. So whatever this was, it wasn't terrible. There's not a lot of scar. That's the best news this person got. Improving function, not playing. You can see over it correlated with echoes that were also showing resolution. Here's an MRV of the pelvis. So this is actually a narrowing of the left condyliac vein. She had twin pregnancies, small woman. So this is not a SCAD at all. We also saw that her atria were enlarged in the echo with the bubble study corroborated a shunt through a PFO. So this is basically an embolic MI to the left main territory, final diagnosis of paroxysmal embolism. And unfortunately, I wish these curves didn't overlap so much. We know pericardium is a terrible time for SCAD risk. It's also a terrible time for thrombus risk. So we want to make sure we correlate and use all the tools in our armamentarium to make these diagnoses. So in summary, I think it's very difficult with any one picture, and of course you have scenes, but it's difficult to spot the stats here. But if I give you the additional information from a CT, you can spot the CAD. I think nearly everybody can. And so the two cases that were actually just mimics, one was a type of mimic of type 3, and the other one's kind of a mimic of inclusion with some irregularity. You can very clearly see the CAD on the CT. So even if you just stick with basics, right? Your hospital may not have as much advanced imaging experience, but you can say, I want to rule in or out CAD, and then combine that with my clinical intuition and information just for follow-ups, and that can help you sort out whether it was truly a SCAD when you don't have a nailed-down diagnosis. The guidelines actually allow for this, and I think it's a useful exercise. And then there's one other thing to talk about. I'm going to quote one of my own very trusted and cherished colleagues in our own cath lab. I was in a discussion with one of the Mayo Clinic guys on Twitter. And so, Farouk says, a gold standard is a cath, but it comes with not so gold complications. And, then we could debate how to make CT better. But, we know that we can cause iatrogenic dissections and worsen things. So we have to be very careful when we're actually entering those coronary arteries. So I think I made a clear argument for those three situations. Some considerations to summarize. If the ideal therapy is non-invasive, ideally shouldn't the diagnosis be. If invasive coronary carries an elevated risk, can it be avoided? So not always. Certain times you should definitely not do a CT, and you should definitely do something invasive, but when you can, and use that. The diagnosis must be made confidently regardless of your modality and carefully. So CT is good for coronaries, so CAD versus SCAD. MRI is good for myocardium, and then invasive coronary artery. It's acute. If you have any kind of a therapy, you're going to be invasive. So the spatial and temporal resolution of cath is superior to CT. However, we really benefit our patients as long as they're stable and we're chasing the small stuff. And I think most interventionalists would be at least give a good pause when we're looking at those distal small vessels. Many thanks, and